Hi, my name is Emily Proehl, and I am a third-year public health student at the University of Florida. Today I'm going to be talking about barriers to breast cancer screening in minority populations of women in the United States. To start us off, according to Alexandriki and Maradian in a 2010 study, approximately 1 out of 8 women will develop breast cancer during her lifetime, making breast cancer the most common non-cutaneous malignancy among women in the United States. Breast cancer can be diagnosed in a variety of ways, according to a few types of medical examinations: the breast self-exam, the clinical breast exam, and the mammography. Women can perform a breast self-exam at home if they know the techniques, motions, and lumps that they are looking for. Upon finding any lumps, women should see their physicians, who will likely refer them to an oncologist who will administer a mammography. The percentage of women diagnosed with breast cancer after a mammography screening ranges from 4 to 7% in that same study by Alexandriki and Maradian in 2010. All of these steps in breast cancer screening and detection are extremely impactful in reducing the breast cancer mortality rate. The success of these early detection and intervention techniques do rely on access to information and education on the topic. This can be a significant barrier to early detection and intervention for women with breast cancer. Common barriers to breast cancer detection and intervention are education and lack of access to care, but breast cancer does not occur in all racial and ethnic groups at the same rate. According to that same Alexandriki and Maradian 2010 study, the latest data from the Surveillance Epidemiology and End Results Program show a higher incidence of breast cancer among Caucasian women, being 141.1 out of 100,000 women, compared to African American women, Asian Pacific Islander women, Hispanic, and American Alaska Native women. However, breast cancer mortality is higher among African American women compared with Caucasian women. In addition, the 5-year survival rate among African American, Hispanic, and American Indian and Alaska Native women also trails that of Caucasian women. The same study also found that the main groups of women who are affected disproportionately are Native American and Alaskan Natives, Hispanic women, women of lower socioeconomic backgrounds and in rural areas, uninsured women, and those without a usual source of care, women over the age of 70, and recent immigrants who have not achieved the Healthy People 2020-10 objective of 70% participation in the mammography within the prior 2 years. In another study by Mary Ann Kelly and Anita Cumley in 2001, Black women specifically cited barriers to breast cancer that were found in low adherence to detection practices, such as discomfort with the process, the impersonal care from healthcare providers, a lack of insurance or funds to pay for mammograms, unawareness of the availability of assistance from community agencies or other departments within the healthcare system, lack of access to transportation, feelings of fatalism, or perceptions of helplessness or powerlessness and fear. Similarly, Hispanic women cited the lack of a regular physician, the lack of insurance coverage, a conveniently located facility, access to transportation, and problems with taking time off of work. Asian women cite an unawareness of mammography tests, gender and modesty considerations unique to their religious beliefs, and fear engendered by a sense of vulnerability to breast cancer. Breaking it down even further by age ranges, older women of color appear to be even more disproportionately affected by breast cancer mortality. According to a study done by Bernstein, Moltster, and Bernstein in 2000, older women of color tend to have much lower rates of mammography screening of breast cancer than younger Caucasian women, yet they have higher rates of mortality. They also found that older women of color have a high risk and a high mortality rate for breast cancer, but in most states, older women of color have much lower regular rates of screening than younger non-Hispanic Caucasian women. From a study done in 2001 by Mary Ann Kelly and Anita Cumley, they also support this idea in that they also found the highest overall incidence of breast cancer in the United States is found among white women. However, overall mortality is highest among Black women. Karen Bullock and Sarah McGraw looked further into the relationship between race and rate of cancer screening in their 2006 Screening Older Minority Women project. They sought to challenge the idea that Black communities are, quote-unquote, hard to reach by investigating community-based approaches in breast cancer reduction. They found a severe discrepancy in incidence rates of breast cancer based on race compared to the mortality rates of breast cancer. From 1990 to 1996, the incident rate of breast cancer for white women was significantly higher than all other women of different races, but the mortality rates for white women was significantly lower than that of black women, Pacific Asian Islanders, and Hispanic women. They found that by enlisting the support of community leaders and sending outreach workers that are women of color themselves into the communities to recruit on health intervention strategies, community members were more likely to utilize breast cancer screening services for the sake of early detection. Another racial community working towards intervention-based solutions to racially disproportionate effects of breast cancer are the American Indian and Alaska Natives population. This community established a national resource center where materials are shared between tribes called the American Indian Alaska Native Center Cancer Information Resource Center and Learning Exchange, or commonly known as the Native Circle. This resource center is located in Rochester, Minnesota. The goal of the Native Circle is to ensure educational resources among their tribes and communities in order to develop cancer control programs. Overall, barriers to breast cancer screening can be culturally bound. Each minority group has its own racial identity and cultural background that influences how they approach health outcomes. Cassandra Simon, in 2006, found that despite their individual cultural practices, cultural barriers to breast cancer screening share similarities in their approaches to solving the issue. She found that techniques that had success were the inclusion of indigenous supports, using community member survivor testimonials, religious solidarity, as well as the acknowledgement and incorporation of cultural norms specific to that group. If we approach these communities according to their own cultural terms, we can begin to reduce the disproportionate breast cancer mortality rate found in minority populations. Do you think policy interventions involving Medicare or Medicaid would encourage breast cancer screening for minority women? Can you identify a community-based solution for increasing breast cancer screening awareness?